So you'll have fun. Andrea has spent a lot of time working globally, and today we'll be talking about her experience working, living in Sierra Leone during the Ebola crisis fairly recently. And I've asked her to, if it's convenient along the way, to talk a little bit about thoughts that she might have on the Zika virus, which is the newest emerging infectious disease that we're going to be confronting. So we welcome you to help us think our way through the emergency response to Ebola.
Wonderful, thank you. Thanks to everybody for coming out. Let me turn this off. I appreciate you guys all sharing your lunch hour with me. I see a lot of familiar faces in the room. Thanks again. So today I'm going to talk about the part of the Ebola outbreak that we don't hear as much about, and that's the collateral damage. And what you'll understand a little bit later on what I'm talking about when I say that. So thank you for the introduction. And just to give you guys a little bit of background, so I was working in Sierra Leone. I was running Ebola isolation units for International Rescue Committee. My official title was Case Management Coordinator. So we had 3 isolation units throughout the country, and I helped to oversee some of those units, which is where a lot of this experience and a lot of my thinking on this has come from. And then subsequent to that, I spent 3 weeks working as a consultant during my quarantine period in Switzerland, where they don't have a quarantine, thankfully. So I spent those 3 weeks working as a consultant for the World Health Organization to help them in their emergency trauma and acute care program has been working to try to help build emergency and acute care systems. And there were some particular aspects of Ebola that applied to that area, and so that was one of the reasons that I was there. So I'm going to tell you a story, okay? And our story starts with a bat, a hungry little boy, and a broken healthcare system, okay? At least we think. We're pretty sure the bat was involved. We know the boy was involved, and the broken healthcare system was definitely involved. So in December of 2013, the person who has been identified as the index case was a little boy, and they think that what happened was he and some friends killed a bat, grilled it, and ate it, which we call bushmeat. It's readily available and cheap, and so this happens very frequently in a lot of countries. But the process, so some people have asked me about this grilling thing, heat destroys Ebola, right? But the problem is not the grilling. The grilling actually probably helped. The problem is in the killing. That's when you get exposure to the blood. So we think that this boy was exposed to the blood in the process of killing this bat. The next thing that we know is in December, he died of some mysterious hemorrhagic illness. Then his mother died, his sister died, his grandmother died. Okay? Over the course of the next several months, we saw sort of a smattering of cases that all could relate back to contact with someone with this boy or this boy's family or someone that had contact. And then around August, everything took off. Okay, so the blue line here is total cases in Guinea, red line is total cases in Liberia, and the green line is total cases in Sierra Leone. Now what happened here that caused this exponential increase, there's a lot of theories on that, but what we do know is that this started acting like our worst fears about what Ebola can do. Okay? And the rest is kind of history. And then this is what West Africa looked like for about a year. So the world focused on Ebola, and then the local people in the background trying to live their lives and survive. This was an article that was published in 2011 about the relatively minor public health threat that Ebola posed for Africa. Hindsight's 2020. The interesting thing, though, about this article is that they're not entirely wrong. Okay, the article, what they're saying is that this virus that was discovered 50 years ago, in that time it's only killed about 1,600 people. And at that time they were saying a lot of effort and money has been put into this, but it's a very relatively low impact. The thing that these authors didn't consider and that the world at large didn't consider was the collateral damage. Okay, so if you look, Guinea has a population of about 11.75 million people. Sierra Leone has a population of about 6. And then Liberia has a population of about 4.3. About 11,300 deaths as of the most recent situation report on February 10th. In the grand scheme of life, it's not that many people. That's horrible. Every life that's lost is a catastrophe. But if you're looking at disasters and global response, 11,000 people out of almost 20 million, isn't that huge. The thing that made this bad, though, was the collateral damage. Okay? So what happened was we had these 11,000 people, and this started out in this sort of sputtering of a dozen people, then a few hundred people, and everybody expected this to do what it has always done, and burn through a village, and then stop. But it didn't do that. It kept going. Okay? And then as it kept going, we started seeing other health impacts. And then we realized that this was a problem. And that was what ended up causing the delayed response. So let's talk a little bit about the effect of Ebola on the healthcare system. Okay, so we had the 11,000 people that died, but then there was a broader effect of Ebola, and that's what I want to focus on today. First is access to care. So you have people who are afraid to seek care. Okay, fear ran rampant with Ebola. That was Ebola's biggest weapon, was people were deathly afraid of Ebola. It's a horrible disease in all senses of the word. It causes you to feel miserable. It's a very visible, horrible death. And so people were very afraid. They also don't really understand it. In Sierra Leone in particular, there's a lot of beliefs. About 90% of the population belong to secret societies. There's a lot of belief in witchcraft. Okay? And people thought this was witchcraft. And, you know, I come in and say, it's not witchcraft. It's tiny little particles that you can't see that are spread from person to person. And it's going to kill you. They're like, your witchcraft, my witchcraft. I mean, they're all kind of, right? And then we came in and we didn't really understand it. So we gave mixed messaging. So we started out with some messaging in the beginning that was if you got Ebola, you're going to die, to try to keep people from getting infected. But then when they got infected, they said, oh, I'm going to die. I might as well die in my bed in my house. My wife taking care of me rather than people in spacesuits. Okay? There was also some thought that maybe it was foreigners or it was the healthcare system attacking people, specifically injecting them with Ebola. So they thought vaccines were causing Ebola. Okay? And again, you have to understand the context. Sierra Leone and Liberia in particular are two countries that have just come out of civil war. There is not a lot of trust in the system as a whole. Okay? And both of those areas, and Guinea as well, have really their healthcare systems are not where they need to be. So people say in the best of times, our healthcare system wasn't helping us. So now what's going to happen? Okay, so you have people that are specifically not trying to seek care. They don't trust the care that's given. So we talked a little bit about that. They thought people were injecting them. They didn't understand why tubes of blood were being taken. Okay, in a culture where oftentimes you go to a pharmacy and they put an injection, they put an IV in, give you a dose of medicine, and then take it out. We were coming in, putting IVs in, and leaving them there. And then we were putting this fluid in that was constantly running. So what's going on with that? Okay, so there's a lot of perception and mistrust and fear. And then you've got healthcare workers who are afraid to go to work. Okay, healthcare workers are dying in droves. And the best of times, they don't have they don't have gloves, they don't have water to wash their hands. One of the hospitals that we worked in Sierra Leone, only 2 of the about 10 wards in the hospital had running water. The labor and delivery ward had 1 set of eye protection, of eye masks. That's in the best of times. So now you've got healthcare workers that you're asking to go and take care of people, and they don't have the resources to take care of them, so they don't want to go to work either. The healthcare workforce, okay? There's already an inadequate number of healthcare workers, and they were decimated. If you look here, this is the percent of the general population killed by Ebola. Okay, again, not too many, it's a small percentage. But look at the number of healthcare workers. As high as 8% of all healthcare workers died in Liberia, 6% in Sierra Leone. Okay, This is in an area that has an estimated need of about 43,000 healthcare workers to meet the 80% coverage, 80% healthcare access that's mandated by the Millennium Development Goals. Prior to Ebola, they had 7,500 in all 3 countries total. Okay, so they've got less than 20% of the workforce that's estimated to cover the area, and then they lose up almost 10%. So there's just not enough people to go around. And then we've got this huge healthcare crisis coming in. People are scared. They're putting in money to this. And the healthcare workforce is needed to man the Ebola isolation units, or to man the hospitals, or to help do contact tracing. Okay. We've cut off funds basically to all 3 of these countries. They have a trade embargo. Okay, so nobody's coming in to trade with them. They're losing jobs. They're losing their ability to provide for themselves and their families. And the only thing that's paying is the Ebola response. Okay, so people are leaving their posts that they might have done voluntarily or for lower pay before, and they're going to work in Ebola-related activities. Again, so I talked a little bit about the finances, but there's a broken supply chain. Okay, so now we have a hospital that has running water in 2 wards on 1 set of goggles, and what little supplies they were getting before, they now can't get because we've cut them off, right? And then we have food insecurity, okay? So if there's a lot of the economy of these countries is based on subsistence farming. If you get Ebola, or you have even people think you might have Ebola and you're quarantined for 21 days, and that happens to be during planting season, what happens to your family for the rest of the year? Okay, food insecurity then leads to poor baseline health. Okay, so we know malnutrition can play into a lot of these other illnesses, pneumonia, malaria. Okay, so this is just getting worse, right? We're getting the snowball effect. And then finally, just as a side note, you have a lot of foreign organizations that are largely left in charge. Okay, this is pluses and minuses. Okay, foreign organizations bring in money and they bring in the cameras. Okay, so the rest of the world sees your plight. But you also have people that are there for their own interests, and those interests may be very noble. But if my interest is in providing corn to starving people, and that's not what they need, then I've just created an extra problem. Okay, so you need to have someone that's overseeing, that knows the culture, that knows the area, who can oversee these foreign organizations. At this point, at the point where we started seeing an exponential increase, very few health systems in the world could handle that. Okay, so you do sometimes need outside help, but that outside help needs to be reined in and utilized by people who know the area. Okay, so we talked sort of in general terms. Here's a few specific examples of healthcare impacts of Ebola. Okay. Oh, here. I just gave away my punchline there. Hate it when that happens. All right, so if anybody was looking down, what is the deadliest animal in the world?
Mosquito.
Mosquito, yes, yes, mosquito. So the deadliest animal in the world is a mosquito, even beating out us, even though it seems like we're trying our level best to catch up. Mosquitoes, okay, kill more people around the world. That's due to malaria, dengue, chikungunya, Zika now on the horizon. Okay, so they are the most dangerous animal. And Guinea, Sierra Leone, and Liberia happen to be chock full of them. Okay, so they had a malaria problem prior to all of this. And now these mosquitoes are running wild. Okay? On top of that, we now have a healthcare system that can't deliver even the level of care that it was delivering before Ebola. Okay? So if you look at this graph, this is Guinea, Liberia, Sierra Leone, and total. It's a little bit of a busy graph, but I like how it displays the concept. Okay, so these blue and green lines here are Ebola transmission. Okay, so they're cases, I believe, let's see, they're suspected and confirmed cases. Then you've got these bars here. These bars are excess malaria mortality. So this is a modeling that a group of researchers did to look at excess mortality. This is not baseline mortality. The baseline mortality is down here, okay? This is the amount of excess mortality due to Ebola. The red bars are people who would have gotten anti-malarials had the healthcare system been intact. These pink bars are people that wouldn't have gotten antimalarials had the healthcare system been intact, but might have gotten hospital services, supportive care, and would have survived. And the blue bars are excess number of cases, so extra cases of malaria because it was so uncontrolled that they also got malaria and then died. Okay? So you can see it sort of follows the pattern with Ebola. And you have, and this is about in, what is this, January of 2015 is where the modeling, where the data stops. If you look in all of these areas, there's a second peak after Ebola stops. Okay? The reason for that is because there is lack of trust in the healthcare system, not enough people to treat, lack of access to medications, all left over from Ebola. Okay? If you look, the estimated increase in mortality in Guinea is 35%, 50% in Sierra Leone, and 62% in Liberia. Those are extra people that are going to die because Ebola was there. About 10,900 people are estimated, so almost as many as Ebola killed in and of itself. Okay. Then we look at maternal mortality. Okay. So if you look here, this is the number of doctors, nurses, and midwives in Guinea, Sierra Leone, and Liberia, and those are the numbers we talked about already. So you lost about 1% in Guinea, 8% in Liberia, and 7% in Sierra Leone. If you look at the maternal mortality ratio, so this is pre-Ebola, how many mothers died in childbirth, which these countries were also some of the worst for maternal mortality prior to the Ebola outbreak. Their estimation for May of 2015, again, this is all modeling, and then the percent change. So in Liberia, 111% more deaths are projected solely because of the loss of healthcare workers. Okay? Now, they also did it for infant mortality rate in under 5. It's a little harder to make those connections to just the loss of healthcare workers and the loss of access to care. So these were not significant, but they're impressive as well. So we're looking at another 4,000 deaths. Okay, so now we're up to about 14,000 deaths, in addition to the 11,000 people that were killed from Ebola. These are the top 10 causes of death in low-income countries worldwide. Okay, the things I just talked to you about live here. We haven't even modeled or don't have data for some of these top killers. Okay? This is the real impact of Ebola. This is the real cost, and this is the reason why all of us in the public health community were petrified of this when it started, when it went out of control. Okay? If you look at the healthcare data pre-Ebola for Sierra Leone, 12,500 pneumonia deaths a year. So pneumonia killed more people than Ebola on a yearly basis at baseline. And that's only in one country, by the way. The 11,300 is for all 3 countries. TB, diarrhea, malaria, malnutrition. Okay, these are the baseline levels of mortality. All of these we expect to be increased due to the collapse of the healthcare system. Additionally, even before Ebola, your risk of dying was actually, you were more likely to die if you got pregnant than survive. Okay, 58%. All right, this is now worse. Okay, this is the scariest part of Ebola right here. All right, again, we're not even seeing this upper level. And then just to add a little more cheer into the day, there was a group that did a study. So in Sierra Leone, they have a yearly outbreak of Lassa fever. Lassa fever is another viral hemorrhagic fever. It's not quite as virulent as Ebola, and it doesn't have quite the same level of mortality. It's still a pretty scary thing. So they looked at samples, at blood samples of patients from 2006 to 2008 who had been diagnosed, who had died of some sort of hemorrhagic fever, but it was not Lassa fever. And they analyzed the samples. And this is what they found. And if you look, the highest number was Ebola. Okay? Now, this is even more scary because they couldn't analyze all the samples for all the viruses because they didn't have enough in all of the samples. So this is just of the ones they tested. 8% were positive for Ebola. So this tells us Ebola was there before all of this happened, okay? Which means Ebola is probably going to be there after all this is done, all right? So what are we going to do? How do we get out of this? Okay? I have painted a pretty bleak picture of the state of healthcare in these 3 countries. What are we going to do? Okay? So, for those of you guys who have any training in public health, you probably were beat over the head with this. So these are the system building blocks, the 6 system building blocks of a healthcare system from WHO. And I remember, I took a healthcare system class when I was getting my MPH, and I remember thinking, this is the most boring thing I've ever done in my life, and sitting there and just and not understanding why I was having to deal with all of this, having to learn all of this. And now it's what my career is based on. Okay? So just goes to show you. But one of the things that's, if you look, these are the building blocks here are pretty intuitive, right? So it's service delivery, health workforce, health information, the medical products of things that you use to treat people, financing, having some way to pay for it, and having some governance system, okay? These things lead to improved access to care, improved healthcare coverage, improved quality of care, and improved safety for patients and for the people that participate in the healthcare system, so the providers, okay? The thing about the health systems, though, is we've been trying to get health systems in place for a long time. But if you're, again, there's a lot of people that were like MPH student me out there that are like, this is so boring. I don't want to talk about this. Let's talk about something exciting. But this is so important. And so trying to get people to understand this has been really important and been very difficult. But when you look at what happened with the Ebola outbreak, okay, that is why this is important. That is why this diagram is important. Because if you don't have this healthcare system in place, if you don't have a healthcare system that can adapt in place, then thousands of people will die, okay? So how do we make a system functional in a disaster? So it's got to be scalable. So I really like this concept of scalable systems, okay? As an emergency medicine doc, this is, my patients don't make appointments with me. Some days I go and I'm twiddling my thumbs, although not very often at the general. And then some days you show up and it's like those old Verizon commercials, where all those people are behind you and you're like, what are you doing here? Okay? You never know what's going to happen. You never know when a disaster is going to strike. My first day in Tanzania, a 16-story building collapsed within my first 2 hours of being in the emergency department. So you never know, okay? So you have to be flexible. You have to have a system that can adapt to that. So the way that you do that, so one, you have protocols and standard operating procedures, okay? By having these set ways of addressing disasters and crisis in healthcare, it makes it easier for you in a time, so if you, let's say early on in Guinea, when you were having those 50 cases, okay, and there were 50 cases that were first announced in December. So you have those 50 cases, and they're most likely all coming in the same healthcare facility, okay, because they're probably are all contact with each other. They're coming in somewhere nearby. If you have standard operating procedures, if you have protocols, if you have ways of managing your infection prevention and control, you can bring in people from another hospital. Say, okay, we're getting killed here. We need to address this. It's getting unsafe. We've got too many patients. I need you guys to come in from this hospital and you guys to come in from this hospital. We all speak the same language. We all know what we're doing. I need you to come in and try to address this now, okay? Rather than let it run out of control. You need, along with that goes well-trained human resources. Your staff need to know how to manage a disaster. And this is from all levels. This is your doctors and nurses and midwives and cleaning staff, and everyone in the healthcare system needs to know how we manage this. If we get to this level of patients, this is how we adapt. Okay? You need to have the ability to mobilize physical resources as well. Okay? So this is the same thing. You're in an area where you don't have enough gloves. Okay? So one of your hospitals is being hit with an unknown viral hemorrhagic fever. Okay? The one universal thing about unknown viral hemorrhagic fevers is you need PPE. Doesn't matter what it is. If someone has a fever and they're bleeding from some orifice that did not have trauma, you need to have PPE on. Okay? So if you have supplies of PPE at all of your hospitals, you may have small supplies because, again, I'm not Bill Gates. Or I was going to say Donald Trump, but he probably wouldn't give any money to that. But, you know, there's not an infinite supply of resources. But if you have a small amount of resources at multiple hospitals and one hospital is being hit, you can mobilize resources from other hospitals and bring them in to try to contain this. You also have to have trust in the system. People need to know, both patients and providers need to know that if they come into the hospital, they are, one, going to be as protected as possible. Two, they're going to receive or be able to give the highest level of care possible. Okay? That's why the system has to be in place ahead of time. Okay? This is not something that you want to be doing in the middle of a crisis because it's too late. Okay? In Sierra Leone, we could tell people as much as we wanted, I'm a good person, I promise I'm not injecting you with Ebola. Okay? That doesn't matter. They have a history and they have fear. Okay? And trying to talk to somebody who's petrified for their lives and their children's lives and their families' lives and to convince them that you don't know me, but trust me, okay, that's just not going to happen. You need to have this set up already. Coordinated response mechanisms. So you need to have a system of communication already. So we talked a little bit about mobilizing human resources and mobilizing physical resources, but you need to have some sort of communication and administrative structure in place to be able to do that. Okay. Patients have to be able to access care. Okay. Now that can mean in the Ebola outbreak, we started setting up isolation units and treatment centers in areas that were hardest hit. Okay, that can be hard to predict, but you want to make sure that people have access to these treatment centers and isolation units. It can also include non-physical barriers like entrance fees. Okay, if you're charging people an amount of money that they can't afford to come and get health care before they can even be seen, you're going to have excess mortality. People are going to die. Okay. Now, I'm not saying that you shouldn't charge anything. Okay, that's a whole other discussion about sustainability and all of that. But you cannot have finances be a barrier to care. Okay. You need to have active surveillance. Okay, especially with a infectious disease outbreak, you have to make sure that you are looking for cases. Okay, I can tell you what happened with Ebola, what happened with cholera when I left Sierra Leone and then went to Tanzania and they were having a cholera outbreak. I think I should just stay put. I think I'm bad luck. But when you have these infectious disease outbreaks, I know, you guys are like, just go. So when you have these outbreaks, there's a lot of stigma that's associated with these infectious diseases. Okay, people don't want to claim them. I had a patient who came into one of our isolation units and kept saying there was nothing wrong with him. But the contact tracers had brought him in, and he kept saying there was nothing wrong. He felt fine. And we were trying to decide if we were going to admit him to the isolation unit or not. And he started vomiting while he was sitting there, and I thought, well, he's just vomiting. He's denying all of the other markers on our case definition. But the contact tracers seemed pretty convinced, so he said, we'll bring him in. And as he got up, he was wearing white basketball shorts. And he started to walk into the unit, and right down here, he had blood coming out. So he had been having rectal bleeding, and then he walked into the unit and vomited about 500 mLs of blood as he got in. But he didn't want to tell anybody. Okay, he knew, because as soon as he vomited, he knew the gig was up and that we knew that, that he was a potential case. But the problem is that there was so much stigma to his family. His whole family was going to be quarantined. I don't know what their profession was, but if they're subsistence farmers, no crop this year. Okay, there's a whole other realm of social reasons why people don't want to come forward. Okay, so you need to have active surveillance, and you need to also have mechanisms to try to help people get through that, to make it not, again, that goes back to having these barriers, right? If your whole family starving over the next year is the consequence of you presenting for care, that's a pretty solid barrier to healthcare. Okay? And you also need strong local leadership. Okay? You need somebody who's on the ground, who understands the situation, who can coordinate this care. Okay? I think that I'm a pretty good doctor and humanitarian responder. Okay? But I'm not Sierra Leonean. I'm not Liberian. Okay? I have my frame that I look at the world, and I have some experience, and I can contribute that knowledge. But I shouldn't be leading this. Okay? You need to have somebody who knows the area, who knows the people, and who knows all the all of the risks, okay? So I've spent all this time trying to convince you that in a functional healthcare system, for a system to function in a crisis, you have to have a functional acute care system, okay? Now, I've been talking about health systems in broad terms, and I've been kind of hinting at this whole acute care system thing. So let me tell you what an acute care system is, okay? Now, I have to apologize in advance. I'm not a graphics designer, okay? And I'm a bear of very little brain. Like, I think of things in a very simple way. So this is how I think of the acute care system. You have a scary world, okay, where bad things happen, like Ebola, okay? And then you've got some sort of healthcare system, healthcare facility, where people go, when bad things happen in the scary world, people go there to be treated and hopefully cured, okay? So you've got all these people that are out in the scary world where bad things happen, and they need to get in to this area, to the healthcare system. But then you've got this guy, and he's following them, okay? And he's trying to give excess mortality. So our job is to stop it, okay? So, scary world, bad things happen to people. Hospital, where they get definitive care, okay? And the acute care system is bridging the gap between those two things and trying to prevent excess mortality, okay? Everybody with me? Okay. So what are these components of the acute care system? How do we frame this? All right. And there's all these terms. This is part of the reason I think that people get frustrated with systems talks, because you start using all these terms and you get lost in them. So here's how I think about the components of the acute care system. So you have emergency medicine. Okay. This is kind of where I live. All right. Emergency medicine are specialists who are trained to deal with acute illness. Okay. They bring people in, they triage them, and then they start definitive care, they stabilize them, and then they decide where they need to go for definitive care, okay? The bigger loop outside of that is emergency care, okay? So emergency care encompasses all of what you do in emergency medicine, but it also includes other aspects of the healthcare system, like trauma surgeons, okay? So trauma surgery for an acutely injured patient, okay? Or say you have a postpartum hemorrhage that's bleeding, okay? So obstetrics. You have somebody who's having an acute asthma exacerbation, so respiratory therapy. Okay, all of these components that deliver care, and what the term that we use is that is high risk for conditions that are high risk under extreme time pressure. Okay, so you have high risk of dying or having something bad happen to you, and you got to act fast. That's what's in this emergency care bubble. Now you have emergency services. Okay, so emergency services are everything I just talked about, plus things like disaster planning, emergency medical services, the people that get you to that definitive care, okay? And then the bigger bubble is acute care, all right? So acute care is anything that is intended to treat, manage, prevent, or rehabilitate any acute care, any acute injury on either an individual level or a population level, okay? So that's the big overarching theme. So basically this is all healthcare that deals with acute illness. Okay, so something that is an extreme risk under time pressure. Cool? You guys with me? Okay. Now, so this whole thing I call the acute care system. All right? Now, how does that play with the healthcare system? Okay, again, my very little brain, this is how I think about this. So you've got this healthcare system, okay? So you've got your acute care system, and the healthcare system and the acute care system are in a very precarious balance. In low and middle income countries in particular, and countries that don't have what we would say like the ideally developed healthcare system, acute care is the way into the healthcare system, okay? People don't go to the hospital until they're very sick. They can't get in, there's not enough people for preventive care. If they're in the US, they might not be able to get into preventive care, okay? So the way that they access the healthcare system is through the acute care system. This makes the acute care system hugely important, okay? Because if you don't trust the acute care system, you will not go to the acute care system and you cannot access the healthcare system, okay? In a lot of areas. If the acute care system gets overwhelmed, okay, so let's say you've got this surge of patients that come in, so something like Ebola, an earthquake, okay, you have some catastrophe happens, you get this injection of patients, If you can't handle it, the system collapses, the acute care system collapses, and the health system collapses with it. Okay? I love this quote. This is from Olive Kobusinge. She's a trauma surgeon at Makerere University in Uganda. She said, emergencies occur everywhere, and each day they consume resources, regardless of whether there are systems capable of achieving good outcomes. Okay? So what this is saying is a lot of people, they say, well, emergency care and acute care is too expensive. Okay? We have to get a lot of, got to get in George Clooney and lots of machines that light up and make noise, but that's not what acute care is. Acute care is having the knowledge and utilizing your resources to manage disasters, okay, and being smart and efficient about how you mobilize those resources. And as Dr. Kobusinge is saying, it's going to happen. These emergencies are going to happen whether we prepare for them or not. So we might as well prepare for them and be more efficient, okay? It's very important to think about this ahead of time. So a couple of ways that we can mitigate things. So during the disaster response, that's usually when it's too late, but there are still some things we can do, okay? So IRC, one of the reasons that I went with IRC and one of the things that I was most impressed with them for doing was they had these isolation units. So we had Ebola treatment units, which are where everybody went and they got tested, and then if they were positive, they got moved to the confirmed portion of the treatment unit. But during the peak of the outbreak, they were overwhelmed. There weren't enough beds for the people who were tested positive for Ebola, much less the people that were still being tested. And you have to give, if your symptoms start today, you've got a 3-day window where you have to be repeatedly tested. So we had people that were living in units for 3 days, taking up beds while somebody who was clearly had Ebola was dying on the street. Okay? So one of the things they did is they set up these isolation units, and they kind of functioned like emergency departments, like Ebola emergency departments. So they were set up, they were full PPE, they were set up to look exactly like isolation units, except our confirmed ward was smaller. And what we did is all patients were brought in to these isolation units, and they were tested. And if they tested positive, they got moved to the confirmed ward, and they got taken to an Ebola treatment unit. If they tested negative, we gave them antimalarials, antibiotics, and then they were to follow up depending on where the unit was with either the hospital or a peripheral health unit or a clinic. Okay? So the function of these units was to test people before they went into the hospitals or the clinics to keep them from potentially passing Ebola, and also to give them a little bit of access to the healthcare system while not overwhelming the Ebola treatment units. So even prior to my arrival, when they set these up, the Ebola treatment units stopped testing unless people walked up. They wouldn't turn somebody away. But the patients started being brought into the isolation units to be tested and then sent out. The other thing that they did, and that helped them to surge, basically. It helped increase the number. We had Saul, who is the sort of designer of this, called it smart beds. So we had beds in our isolation unit that could turn over quickly. So the idea was to test people and get them out, okay? We also employed local staff, okay? That's really important. As I already showed you, Ebola is there, okay? It's been there. It's been in Sierra Leone. We presume it's been in Guinea and probably in Liberia as well. It's going to come back, okay? I now have gained a lot of knowledge about Ebola and how to manage Ebola from being there. And that knowledge is now all sitting with me in San Francisco, okay? Not very helpful to the Sierra Leoneans, all right? Now, this is going to come back, but what IRC did is they trained people they trained local nurses, local medical officers, local hygienists, local cleaners, okay, to recognize Ebola and to know how to protect themselves and protect others from it. So hopefully when this happens again, and it probably will happen again, there will be local staff who know how to manage this, okay? And hopefully it won't get to the point where they need to call in outside help, okay? By empowering people, by giving them the knowledge and the training to do this, they're empowering them to maintain their own health system, okay? Obviously, the international community is there if this happens again, but hopefully they'll be able to organize it, recognize it before it happens, and if the international community is brought in, oversee it, okay? And take control of the response. The most important aspect, though, is preparing for future disasters. Okay, so there's a couple of organizations that have done a really good job of this. One is the African Federation for Emergency Medicine. So they are a group of African physicians, nurses, healthcare providers who are interested in emergency care and acute care and increasing access to emergency and acute care. So they've developed tools for healthcare providers in management of emergencies. So a lot of this is training, okay, and support. So it's how do you manage acute emergencies? How do you manage an acute outbreak? How do you triage patients? Okay, how do you ration your resources? So who is the sickest? Who is the second sickest, et cetera, okay? And then they've supported the development of emergency care in Africa. Okay, so they provide support, they provide training materials. When all of this was happening, they put out a statement. They had a group at one of their meetings to discuss ways to support these countries. Okay. The other thing is the Emergency Trauma and Acute Care Program through the WHO. So one of our own faculty, Terry Reynolds, is actually heading up this program and was the one who very graciously invited me and let me stay at her house, by the way, during my quarantine period. So, but she has taken over this program at the WHO and is leading it and has done some amazing work. So she's been working to create a toolkit to aid in the development of emergency care systems. So as I have said a couple times, she's the one who coined the phrase, ordinary systems, extraordinary circumstances. Okay? The idea is you have to have a healthcare system in place before this happens to be able to flex, to surge, to manage this, okay, and to try to mitigate some of that excess mortality that we were talking about. So the components of this toolkit are this emergency care systems framework. So what are the essential components of an emergency care system? And then an assessment tool to look at those components and say, you know, what are we missing? What could we work on from the Ministry of Health perspective or the systems perspective? This basic emergency care course, which is a little bit like a basic life support for low and middle income countries. So it's a basic level of emergency care that is taught to doctors, nurses, midwives, anybody in the health system, to then build upon. So a lot of this is triage, which we learned a lot about in Ebola, okay, and how you triage those patients. Trauma care checklist, this is more of the trauma aspect of this. So for things like an earthquake or those kind of disasters, how prepared are you to manage trauma, and then keeping up with the injury data set. So just in response to talking about Zika, so Zika is going to be very interesting because, so if you look at 3 different disasters, so you have Haiti, you have Ebola, and you have Zika, okay? Haiti was sudden, impressive, overwhelming, done, okay? There were some aftershocks and there were some other people that died after due to structural instability and things like that, and then cholera later on. But the bulk of the deaths in the Haiti earthquake happened when the earthquake happened. Okay, so there was an acute loss of the healthcare system, and there wasn't much of a functional one to begin with. And then they've been building back. Okay, Ebola was a little bit more indolent. Okay, because we sort of were watching it, 50 or 100 people. That's not that many people. On the scale of, Haiti, there were 220,000 people died. So you're saying, well, let's keep an eye on it, let's watch it, and then this is what happened, okay? So because it had that sort of indolent spread, it had a much heftier impact on the healthcare system. And I expect, I've shown you what the models were for the next year, but I expect that those numbers are going to stay bad until we get the healthcare system back up to par. And a lot of people have been working on that, but it's going to continue to have an effect in the future. Zika is incredibly indolent. Okay, Zika does not make you bleed out of your eyeballs. So people are not necessarily seeking care. It's like a flu-like illness. Okay, so a lot of people that have Zika don't even know that they have it. It's not something that's as scary. It's not something that that you have immediate rewards for. So you don't put on the big Ebola isolation suit to remind you not to get Ebola. You have to put on some DEET every day, all the time, okay, for a long time. So it's going to be really difficult to control, and I think it has the potential to have an even bigger health system impact, okay? Because if in a year or two we start having thousands of microcephalic babies, that takes up not only, well, those children may die, but they're going to require a lot of care. That's going to mean parents are going to have to stop working. Productivity is going to drop. Food insecurity is going to go up. Okay, people can't provide for their families. They can't, they're dedicating all of their resources to taking care of this child who is likely not ever going to be productive in society. I think this has the potential to have an even bigger impact. And it's a little scary because it's something that can be kind of taken lightly until it hits. And once it hits, we have anywhere from, 18, 20, 30 years of having, these children that we have to care for and that take up resources. So I think this is one, again, where having these systems in place, emergency care systems and healthcare systems, having surveillance in place, making sure that people trust the healthcare system, they have access to getting into the healthcare system, and giving them access to preventive tools, I think, is going to be key. So, on that note, as we wrap up, okay, as we think about this, so thankfully we're coming out of this, okay. There are, I think, still going to be scattered cases in West Africa, but as West Africa starts to recover and the world starts to recover from this Ebola outbreak, I think we have to start thinking about what happened, why did this happen, how do we prevent it from happening, what can we put in place to keep something like this from happening again, and how do we mitigate some of that damage that's already been done? How do we help those mothers who got pregnant, or, the women who got pregnant? One of the other things is with the education system, schools were shut down. There were actually a lot of teenage pregnancies, mostly by older men, because kids weren't in school. And now those women have lost some of their ability to have an education, which we know the mother's education has a positive impact on the child's outcomes, okay, and their survival. So how do we mitigate some of those things? Okay, it's going to take years for us to figure out just exactly how much damage Ebola did. Okay, what I showed you today was all projections and models. We don't have the data yet. There's one study that was done, was very interesting. They looked at grave, so people that they had grave burial teams, and starting in November in Sierra Leone, they started swabbing all the dead bodies to try to see if they were missing people, if they were missing Ebola cases. But a research team went back and looked at the swabs from November to April, November 2014 to April 2015, of patients who tested negative for Ebola. How many dead bodies of patients who were negative for Ebola there were? And there were almost 3.5 times the number that had been recorded in the last 4 years for that period. So almost 3.5 times as many people died not of Ebola, just because of the impact. So that's the first set of data that we have coming out about this. There's going to be more, okay? But it's going to take years to figure that out. And we don't have years to prevent this, okay? We have to start acting now. We need to work on these healthcare systems, need to start working on advocating for improved access to acute care systems. Fortunately, some of that work has started, okay? And hopefully, if I did my job well, I've inspired some of you to come join me in that fight and join the other people that are working pretty tirelessly to help with this. So with that, if there's any questions, please let me know, and feel free to contact me as well. So, any questions? Yes.
What was the last photo?
Oh, I'm sorry. So this was actually taking down one of our Ebola isolation units. Yeah. So this was, everything had to be burned. And so this was one of our units as we decommissioned it. That was, yeah.
You alluded to, thank you very much.
Thanks.
You alluded to the fact that some of it is just access to acute care, and I know that it sort of gets outside the realm of healthcare systems into, are there social systems in place that can provide disability or what have you to account for the fact that these farmers will no longer be able to have any crops for the rest of the year?
Mm-hmm.
Are there any movements to include other government agencies and departments to try and tackle that?
Yes, there have been. It's a little slower going. It's easier to make the healthcare argument than it is to convince businessmen that, of the broader impact of some of these things. But there are definitely groups that are working with that. World Food Program has been working a lot with food insecurity and with monitoring food insecurity, and they call it negative coping mechanisms. So those are things like eating bushmeat, things like that that people are doing to try to cope, and they're monitoring those parameters and trying to advocate for assistance for food, better food security. Then there's also some groups that are working for things like some of the social reforms and even during the disaster. I mean, one of the things as a physician that was, it's funny, like you come in as a physician to that and you realize that you're kind of the weakest link there. You're not really the person that is the most essential. So, my job was kind of overseeing these units and making sure that we were giving the care that patients needed to get. But a lot of it was making sure that the laundry staff had long gloves so that they weren't getting burned with all the chlorine, so they could wash the clothes and keep everybody safe. And then we also worked really closely. We would discharge people, but then they have this problem of their stigma. We had somebody who got evicted. His landlord, just because he was in the unit, he tested negative, and his landlord evicted him just because he'd been in a unit. He didn't want any of that stigma associated. So we had a group of social workers who were amazing. They would go out and do this community mobilization to go in advance of our patients being discharged back, to go back and talk to people about what it meant to have tested negative for Ebola. You weren't a survivor, you didn't have Ebola. It was kind of this, it was very interesting, a lot of that interplay. And so it definitely was, as a physician, it was very humbling, but it was very impressive, the amount of work that was being done. And a lot of people, a lot of our Ebola operations in IRC were run by educators, because they were there working and they kind of adapted, but a lot of what needed to be done was messaging and informing people. So, yeah.
Thank you very much. As somebody who was late to an Ebola crisis in 2001, and listening to what is happening in West Africa, there's a huge problem on daily needs, for example, human waste.
Yeah.
Could you speak a bit about how that is being handled? Lots of urine and human waste. When the Ebola crisis ended,
yeah. No, that's actually, so that goes back to this picture, actually. That was a good segue. These are our latrines in our Ebola isolation unit. And one of the things that we had to deal with, so there's two aspects of that. So one, you had Sierra Leone in particular. I can't speak to the other countries because I don't know them as well, but Sierra Leone, open defecation is a pretty common thing. And even in the middle of the Ebola outbreak, we'd be driving through in our, IRC truck and all of that, and you'd see somebody having a bowel movement by the side of the road.